To welcome those who are here in person for turning up and attending this seminar, and to those who are online. It is my pleasure to say that this is our second seminar for the Trinity Research and Childhood Centre, and I'm going to pass you over to Professor Nicola Carr, who will introduce our speaker, who we're very privileged to have here today. Thank you, Imelda.
Hello, everybody. We'd like to welcome Dr Christian Connell, the Kenyan Family Professor for Healthy Children and Director of the Child Maltreatment Solutions Network at Penn State University. He's here today to present to us on advancing interdisciplinary research on the effects of child maltreatment and formal state involvement for children and families, and on Penn State's Child Maltreatment Solutions Network. So I'll hand over to you, Christian. I look forward to hearing from you.
Thank you. Thank you. Good afternoon, folks. And I know we've got people online as well, or may have people online as well. So I'm really happy to be here today. Appreciate the introduction. I also just want to say before I get started, I'm really deeply grateful to the leadership and faculty at the Trinity Research and Childhood Center, or TRIC, for hosting me this past month. I've been privileged to be on sabbatical from Penn State for a month, and this visit has been incredibly enriching for me professionally, offering opportunities to connect and engage with folks at TRIC and Trinity College, attend some seminars, meet with faculty, and connect with new and potential colleagues and collaborators in Dublin and beyond. Some of the highlights, just to touch on my experience here, I had the opportunity to share some of my team's work on integrated data at TUSLA earlier in the month. Engaged with folks at the University of Limerick's Research Evidence into Policy Programs and Practice, or REP project, attend a national conference on diversionary practices for youth in juvenile justice, and also meet with folks at TUSLA and with the blank on the acronym, the TEID.
TCEI.
There you go. Yes, that's
Quite a lot.
Right, it's a tough acronym. I'm used to acronyms. That's a tough one, but around some of their efforts to develop a program for research around care pathways for youth involved with TUSLA using integrated data. So it's been just a tremendous opportunity to connect with folks here. And I also just want to say that I'm really thankful to Professor Sinead Tobin and the TRIC team for all of the efforts they put into making this such a impactful visit for me. So my focus today is I'm going to be going over the role of interdisciplinary research in advancing child maltreatment science, an area that I know TRIC and Trinity College also has a rich history of involvement with. I hope the talk resonates with some of the work that you all are doing in this space. My goal here will be to kind of give an overview of how Penn State has approached the idea of interdisciplinary research, and particularly some of the research infrastructure that we've developed. I may give you a smattering of results and studies underway in some of this work. I'll try to keep my remarks around 40 to 45 minutes to allow some time for questions and discussions. And if I skip through some slides quickly, feel free to ask me. I'm happy to send these in the future. So before I do get started, I have just a quick disclosure I want to make. First, I do want to acknowledge that a lot of the work that we do at Penn State is funded through an endowment that I'll describe, but also through significant funding from the Eunice Kennedy Shriver National Institute for Child Health and Human Development, or NICHD. And I also want to just stress that some of the results that I'm presenting today, especially based on our work with state collaborators, reflect the views of myself, my team members, and the faculty involved, don't necessarily reflect the opinions of those state collaborators. So let's put this in context a bit. I want to start by framing child maltreatment as a public health issue. And when we talk about child maltreatment, we're talking about a broad range of caregiver behaviors that include child physical and sexual abuse, as well as adverse parenting practices like emotional abuse or caregiver neglect, which could encompass things like failing to provide supports and appropriate care for children. But it could also include things like inadequate supervision, inadequate access to medical or educational supports, or basic necessities. In the U.S., sorry, too many screens up here. In the U.S., state and child protection service agencies are primarily responsible for the formal response for identifying, investigating, and providing services to children and families affected by maltreatment. And in 2022, State child welfare services across the country received approximately 4.3 million referrals for suspected maltreatment involving about 7.5 million children across the US. So significant number of children impacted. The calls resulted in over 2 million investigations or alternative responses for about 3 million children. And nearly 1 in 5 of those investigations resulted in some finding of an affirmative case finding, substantiated or indicated report. And that includes about 2,000 fatalities across the country related to child maltreatment. At the national level, among victims in the US, neglect is the predominant form of child maltreatment victimization, accounting for over 75% of positive case findings, with physical abuse, sexual abuse, psychological abuse, and other forms of maltreatment coming in much lower. Pennsylvania is, one state in the US. One of the things about the US that differs in terms of our content for child protection from the Irish system is that we are very decentralized in our focus. So while the federal government sets kind of minimum standards for how to define child maltreatment and how to respond to child maltreatment, each state has their own way of dealing with child maltreatment. So unlike the US, which has unlike the Irish system, which is the national approach. Pennsylvania is what we call a state supervised or county administered child welfare system, meaning that while we have a centralized state agency that's responsible for overseeing operations across the state and managing the budget and the central child line, each of our 67 counties actually has their own child youth service agency that's responsible for the formal programs for child protection in the state. And in Pennsylvania, we have 2 tracks for that response process. One is Child Protection Services, or CPS, which handles concerns about child abuse, including child physical and sexual abuse or serious physical neglect. And then we have another system called GPS, or General Protective Services, that's responsible for handling a much wider array of child welfare concerns. And that's a family assessment response. So rather than going through a formal investigation, caseworkers meet with the family and try to identify underlying concerns that might be contributing to child welfare concerns for their child. In addition to CPS and GPS, counties are also responsible for providing access to in-home contracted services and out-of-home foster care placements. Many of the caseworkers that serve CPS are also involved in GPS investigations. So although these are 2 different tracks, they're very porous systems. The same service providers, the same foster care providers are eligible to families that come through both of those tracks. And to give you a sense for the scope of our child welfare system, in 2023, we had about 40,000 CPS reports and 173,000 GPS reports for the fiscal year. About 12.5 or 12,500 children were in foster care at the end of the fiscal year, with 20,000 children served in foster care out of home placements during that period. So to put that in comparison to the Irish system, I think during that period you had, if I just check my notes, you had about 92,000 referrals for CPS in that same period of time, and about 5,600 children in foster care. So our system is dealing with about twice as many cases, or just under twice as many referrals and placements. Our child population is significantly larger too. We have about 2.7 million children under age 18 compared to about 1.2 million in so comparable systems, but a very complex system here in our US context. Also, even though today I'm focused primarily on formal system involvement, I do want to recognize that that's really just the tip of the iceberg for children when we talk about child maltreatment. So about 40 to 70% of maltreated children don't actually come into contact with formal child welfare services in the US. And our estimates are that about 1 in 5 children, about 20%, experience some form of child maltreatment before they turn 18. So it's important when we think about child maltreatment. My work really focuses on that formal system involvement, but recognize that there's a broader context in which child maltreatment occurs that we need to be aware of and think about from a prevention context. So there's a strong research base for providing evidence that children who experience maltreatment are at significant risk for a host of developmental, behavioral, and health-related complications. These negative effects vary as a function of age, gender and other sociodemographic factors. So among preschool age children, we know that there's a high risk of involvement for children who are maltreated with developmental concerns, either identification of having developmental concerns as they age into school age period. Children who have disabilities or developmental concerns are also significantly more likely to experience maltreatment for systemic involvement. When we move into school age and adolescent periods, we know that there's a strong association between child maltreatment and experiences of cognitive problems or behavioral problems. So about half of children ages 6 to 17 with a history of maltreatment show some evidence of behavioral problems as they start to go into childhood and adolescence. And when we look at adolescents in particular, we can see higher rates for experiences with substance use and other delinquent behavior activities for youth who have experienced some level of maltreatment. We can also put this in a broader ecological context. So when we think about child maltreatment, children exist in a wider context of family, community, and system level contexts that can increase or affect the risk of exposure to child maltreatment, as well as the consequences of experiencing maltreatment. So those different risk and protective processes could include things like family or caregiver involvement with substance use, parents with significant mental illness or mental health concerns, domestic violence, and then community level or systemic factors like poverty, illegal or illicit behavior, or other factors in the community that can all increase the risks of exposure to maltreatment or negative consequences of maltreatment and can become targets for intervention or service response, as well as policy and practice kinds of changes. So all of that is to say that child maltreatment reflects a complex public health problem that sits at the intersection of multiple systems and disciplines. And as with other complex social concerns like poverty, substance use, or crime, child maltreatment has often been described as what we call a wicked problem, a social challenge that's difficult to solve by any one discipline and really does require us to bring together experts from a variety of backgrounds and disciplines to understand and tackle the concern. So wicked problems are often complex because no single discipline is viewed as having the answers. There's a host of interrelated causes and consequences to the social problem. And there's a diffusion of responsibility in addressing the issue as a result of lack of consensus about how to measure, how to intervene, what the negative consequences might be in different areas. So as a result, it's really important that our research inform broader strategies to address child maltreatment and serve to break down professional and institutional silos. And by doing so, it's our hope that we can motivate more effective public policy and community or agency-based practice response to either effectively intervene to prevent child maltreatment or to reduce its negative effects or consequences. So to advance work on this complex issue, the Child Maltreatment Solutions Network, which I direct, was formed in 2012 in response to a serious sexual abuse scandal that was revealed the previous year involving an assistant football coach at Penn State, Jerry Sandusky, and numerous children over a period of several years. The scandal resulted in a significant multi-million-dollar fine to the university that eventually provided the endowment support to initiate our network. Jenny Knoll, my predecessor, was the founding director of the network, and I took over in 2022 when Jenny stepped down and subsequently moved to a new exciting opportunity at the University of Rochester. Some of you may have heard of the Mount Hope Center, Dante Chinchetti, Sherry Toss Center at the University of Rochester, and Jenny joined that group. The network is housed in the University's Social Science Research Institute, or SSRI. So we have this kind of institutional home that represents across college, across university context, and reflects the university's commitment to developing national leadership and use of research, education and training, and other awareness events to address the complex issue of child maltreatment. The network is comprised of a cluster of faculty supported by SSRI and colleges across the University Park and College of Medicine. We currently have 9 faculty, and we have 2 active searches underway across 5 colleges and 7 departments at the university and at our medical school. We also have network staff to support network activities and 2 faculty instructors who support our educational mission, which I'll talk about in a second. So I mentioned that the network was established in the wake of the university-level child sexual abuse scandal. An important development in supporting the state's child sexual abuse and child maltreatment response was an NCAA, or the National College Sports Association settlement, which established a state endowment for prevention and intervention services and a university endowment to advance child sexual abuse and maltreatment research and educational programs. Broadly, the scope of our network is framed by our network mission to advance scientific efforts, as well as educational and training opportunities to improve outcomes for children affected by child sexual abuse and other forms of maltreatment, and to raise awareness of these issues, inform programs, policies, and practices to advance this agenda. So I'm going to touch on each of these areas very briefly, and some will give me some time because I know we've got lots to go through. So I'm going to touch on these areas briefly. I'm happy to share more details either with discussion later, or if there are questions, people can email me. I'll leave my email address at the end of this presentation. But let's start with the research agenda. I'm going to come back to the work of our center, but the network faculty have been very successful in terms of landing a number of large federal grants from the National Institute of Health, as well as other government agencies, state and national foundations, and a variety of internal university funding. But our largest grant that we have is led by the network faculty and co-funds is the university's Translational Center for Child Maltreatment Studies, or TCCMS, which recently received a 5-year renewal of grant funding from the National Institute of Child Health and Human Development. Dr. Yeo Jackson and I took the reins as co-leads of this grant during its renewal period. And the center includes 3 cores, an administrative core, a dissemination outreach core, and a resource core that provides support for an active research agenda within the university. 2 active research projects that I'll describe in a little bit more detail are the child health study and our safety adolescent outcome and costs study, which is a focus on telehealth services for youth who experience sexual assault. I'll come back to this in a couple of minutes because we're going to do a kind of deeper dive on some of the active research activities in that center. In addition, the network provides seed grant opportunities and grant matching funds to broaden research child maltreatment across the university. So we currently have 3 active seeded grants underway to promote a prevention initiative around child sexual abuse across the state of Pennsylvania, to develop measures specifically focused on adolescent problem sexual behavior. And then we recently provided support to launch telehealth services for sexual assault nurse examiners, or SANEs, for pediatric victims of child abuse. All right, we'll come back to the research agenda in a minute, but I just want to touch on some of our education and training activities as well. So in the education space, the network developed and administers a university-wide cross-disciplinary undergraduate minor in child maltreatment and advocacy studies, or CMAS. CMAS minors come from disciplines across the university, and the minor consists of elective coursework as well as 4 foundational courses to introduce students to issues around child maltreatment and advocacy, evidence-based prevention and treatment methods for child maltreatment and its effects, and exposure to a variety of multidisciplinary community systems that are involved in that child maltreatment response. And the minors kind of capped off with what we call a capstone internship experience in a supervised internship with a community organization that's either focused on child maltreatment or children's advocacy issues, or in a research lab at Penn State focused on child maltreatment research. So they have a pretty rich, intensive experience with an idea about helping students either pursue graduate training in this area of work, or pursue employment out in the field, pursuing things like casework and social work settings like child welfare. We also have an NICHD funded postdoctoral and predoctoral training program, a 2-year training fellowship for students to come and get exposure to mentorship across 4 different domains: biology and health, developmental philosophy. I go through the 4. Developmental processes, policy and administrative data systems, and prevention and treatment. So fellows come, they work with a primary and secondary mentor in 2 of those 4 areas. And they also get trained in the ethics of conducting research with vulnerable populations, grant development, and then translation of research into public policy contexts. And then the last educational program that we offer is a program that was developed and implemented by the Child Maltreatment Solutions Network called Fostering Alliance, which is to provide support for youth with a history or active involvement in foster care who are now entering the Penn State and our Commonwealth college system. So we provide ongoing support, connect students to vital university and community courses, and provide skills development to help students successfully matriculate through the Penn State experience. We've got about 60 students active in the program now, and we've had close to 200 students who have gone through the FLP program since it was implemented in 2014. And then the last area of our mission really focuses on raising awareness. So in that space, every year the conference or the network organizes a conference on a topic of interest to network co-funded faculty. Our recent conference about 2 weeks ago, I missed it while I was here, but we focused on issues around biological embedding of caregiver diversity. We had international experts come to Penn State and share their research findings around issues of how the kind of adversity that caregivers experience gets under the skin of children in terms of their ability to regulate their distress following experiences of maltreatment. Other recent conferences have focused on supporting crossover youth involved with juvenile justice and child welfare, advancing science in foster care and child welfare service space, use of integrated administrative data, and also innovative research methods for child maltreatment. The conference also produces a book series. I'm going to leave a copy of our book here from each of our conferences, but we do an edited volume based on participants in these conferences. And then in the spring, the network also organizes an awareness event that's intended to reach a broader audience. It's not a scientific event, but a research-focused event, but it's focused more on translational aspects of how do we use the research to inform practice and policy. And so last year we had a webinar event that was focused on provision of appropriate services and supports for substance-affected infants. We've done awareness events, spring awareness events around child sexual abuse prevention, disentangling neglect from poverty, and other evidence-based intervention methods in community context. So very excited also to kind of bring the research out into other kinds of community contexts. All right, so that brings me back to the center. So I wanted to do a deeper dive on some of the research activities that are underway in our Translational Center for Child Maltreatment Studies. So I mentioned that the center grant provides infrastructure support to research activities through 3 cores. We have an administrative core that I co-lead with Dr. Go Jackson in the Department of Psychology that manages the grant, supports a number of external prevention and intervention efforts underway with the network, as well as our School of Medicine. And we collaborate with colleagues in the Research and Policy Collaborative, which is focused on translating and disseminating our research findings into both federal and state policy contexts. Dr. Jackson also leads our resource core, which provides direct support to the research projects underway at the center and oversees communication supports so that we can disseminate research findings in a variety of outlets. And then the final core, the Dissemination Outreach Core, or DOC, I co-lead with Dr. Font in Sociology and Criminology. And that DOC is really focused on supporting applied community engagement research agenda with our state partners. And we also manage access to a host of administrative data sources relevant to the research projects, as well as to our own research activities. And then we have 2 research projects that I'll describe in a little bit more detail, our child health study and our safety center adolescent study. And in our first cycle of funding, we concluded a study on abusive head trauma that has resulted in the development of a clinical tool and protocol that's now out in the field for pediatricians to better identify infants who are affected by abusive head trauma. So a lot of research activities underway through the center. The center is managed by our interdisciplinary training team across 3 colleges and 5 departments. We have numerous co-investigators within and across the university, including outside of our network. So this really is a very multidisciplinary team, heavily influenced by psychology, I will say, and sociology, but draws upon experts from educational psychology, medicine, law, and a host of other areas as well. All right. So I want to take a few minutes to give you a sense of the kinds of research activities and applications underway within the center. And I'm going to start with our two primary research projects, and then I'll wrap up with a deeper dive on the dissemination outreach program, because that's the one I manage, and it's the one I'm particularly excited about. We'll start with our center's largest project. This is the Child Health Study. This is a longitudinal panel study that investigates the effects of formal system involvement for child maltreatment on child and family health. And we refer to it as the Child Health Study, or sometimes just Project One, because it is really front and center in our center. So the Child Health Study is led by Dr. Connell. She's an associate professor in our Department of Biobehavioral Health in the College of Health and Human Development. She's an expert in immunology and kind of inflammatory diseases, but the relationship between adversity and in this context. The Child Health Study is a prospective longitudinal cohort study that focuses on discovering malleable psychosocial, behavioral, and resilient factors to mitigate the biological embedding of child maltreatment effects on youth as they navigate that transition from childhood through adolescence into adulthood. In phase one of the study, core activity was really recruiting and establishing that child health study cohort. Myself as the leader of the doc had to work closely with county systems to develop recruitment strategies using administrative data. That activity, though, is now complete. We've been able to, recruit about 700 youth to enroll in the panel. They were between the ages of 8 and 13 at the point of involvement. About 3/4 of the sample were actively involved in children and services the year before study. So either because of allegations of physical abuse, sexual abuse, or physical neglect. And then we recruited a cohort of 25% cohort of youth who are similarly matched in terms of demographic characteristics, but I know that it's informal system involvement. We do a lot of checking through our administrative data to identify those youth. Children, like I said, were enrolled between the ages of 8 and 13, and then they're followed in our panel study design every 2 years, up through time 6. We'll start to look into that kind of early adulthood period for these individuals. So that's really the focus of the next 5 years of the grant. Reflecting the interdisciplinary and multi-systems view of child maltreatment occurrence, response, and its effects, the Child Health Study involves an extensive assessment and data collection process that encompasses a wide variety of domains and methods. So consented and enrolled youth and their caregivers actually come down to Penn State from across the Commonwealth and spend a day at the university engaged in a variety of data collection activities. And interspersed in that are a lot of different kinds of activities. Penn State is an agricultural school, so we're famous for our creamery, and so they also get a trip to the creamery to get some of our Penn State ice cream. But we try to make it a day that's engaging for youth and families. And it's the non-perpetrating caregivers, I should say, that are involved in this study. So assessments include a range of biological assessments. You can see some of these: neuroendocrine functioning, immunologic functioning, epigenetic, cellular aging, and neurodevelopment. These are collected through health exams with trained nursing staff. Health techs administer a variety of different lab and assay procedures. So they collect blood and saliva, swab, cheek swabs. They do an fMRI to get a sense of brain functioning. It's pretty heavy focus on the biological aspects of the experience for children. In addition, caregivers and youth complete a variety of different assessment tools to assess behavioral health and well-being, including psychological functioning, cognitive performance and executive functioning, family and parent-child interaction and functioning. We look at the home and parenting environment, emotion regulation, and exposure to other stressors and supports. And these data are also then linked with our child welfare records to ascertain histories of formal system involvement. And those narratives are all coded using a validated coding system. So it's a pretty intensive focus on bringing together lots of different sources of data to understand the experiences of children and families. The Child Health Study reflects a tremendous research resource in terms of being able to understand the ways in which formal system involvement and a host of intervening social and behavioral factors contribute to long-term health outcomes for youth across a variety of different domains. And we're also looking at ways that we can bring together into this process a number of other systems like healthcare systems, so we can really understand the service supports that families are engaging as a result of their involvement with the child welfare system. I'm going to give you just a quick sense of some of the research activities that are underway. That's headed the headings on here, but the first study, we've published a number of studies, or the team has published a number of studies that look at primarily at the health outcomes at this point for youth involved in that system. That says nicotine and inflammation. I should say BMI and epigenetic aging. So we're looking at in this study that was published by Edsel and colleagues in 2022 with our team, looking at the association between age and sex-adjusted BMI scores and epigenetic aging, kind of how the impact of obesity and adversity might impact the kind of ways in which stressors show up in your genetic profile. Our findings showed that higher age and sex-adjusted BMI scores are associated with epigenetic aging. The child maltreatment is associated also with BMI, but not directly with that epigenetic aging. So there's this kind of process underway, and our team is trying to disentangle this, where the experiences of youth might be contributing to BMI kind of markers, and then those BMI markers are then contributing to the kinds of stressors that we see indicated in the the epigenetic profile. Other studies underway have been looking at that issue of nicotine use and inflammation and the ways in which child maltreatment might moderate or contribute to nicotine use, and how nicotine use is then associated with inflammatory disease processes for youth. Here, uncovering some clear differences between boys and girls and the interaction between pubertal stage and some of those effects for girls. So really focused on that disentanglement of health and adversity as it relates to child outcomes following maltreatment experiences. The Child Health Study was initiated prior to the pandemic, and the network was very actively involved in a number of studies that were looking at the impact of COVID-19 on families involved with the child welfare system. Unrelated to the study on one slide, I had a team that did some work, population level work, looking at the relationship of COVID experiences to distress in the home and its contribution to the child maltreatment experiences. Capitalizing on the Child Health Study timing, we've had some T32 fellows that have looked at the role of pre-pandemic functioning on children's ability to manage stress following maltreatment experiences, and shows in particular that caregivers who had higher levels of psychological challenge pre-pandemic were also contributing to their children's experiences of COVID-related distress. So, some interesting work in that space as well. All right, we're going to turn to project 2. We're doing okay. All right, which is the sexual assault forensic examination of telehealth safety adolescent evaluation. So this study is based on research that tells us that survivors of sexual abuse or assault require timely, skilled, and trauma-informed health care access to address the injuries, risk of infection and pregnancy, and also to collect appropriate forensic evidence to aid in the justice outcomes for individuals who've experienced sexual assault. Sexual assault can have a significant adverse effect on health and well-being of victims. So over 70% of victims report some level of negative physical, mental, or health-related behavior outcomes resulting from their victimization. And we know that access to appropriate sexual assault nurse examiners can actually minimize that risk. So one of the challenges that we have, though, is that access to these trained professionals is limited. And when we look at a state like Pennsylvania, in particular, access is very limited in rural contexts. So a paper published by my network colleague Sheridan Imelda shows us that in Pennsylvania, 75% of hospitals, and particularly those in the rural central part of the region, don't have access to trained professionals who provide great care for sexual assault victims. And this is due, first of all, to having very few trained examiners in this context, high rate of turnover and burnout among professionals in this context. It's a very stressful field, and disparities in quality of care, particularly in rural versus more urban settings. And so to address that concern, Dr. Imelda and her team and the network developed the Safety Center telehealth response, which provides a kind of central hub for nurses in these more rural areas to access supports and care and guidance and training to implement sexual assault nurse exams for sexual assault victims in their areas. So our Safety Center study is going to be adapting that model, which has been implemented with adults for care with adolescent population, and assess the differences in adolescent short and long-term health and well-being outcomes, as well as differences in the process-controllable decision-making that come with access to this resource we announced at Penn State and available across the state. There's also an exploratory aim that's going to look at that economic cost-benefit analysis of doing this kind of work. So what are we learning from this work? We're in the first year of this study, so we're very early in the data collection process, but the Safety Center has already been conducting qualitative interviews with stakeholders to understand some of the challenges with implementing sexual assault nurse examiner forensic tests in these kinds of contexts, identifying issues with workforce recruitment, expertise and training, as well as case volume, and early work with the adult population before we implemented the adolescent study shows that having access to these telehealth supports and services improves post-consult satisfaction among nurses and confidence in their ability to manage this investigatory process, as well as patients' satisfaction with care. So really impacting their sense of support. And we've also seen significant increases in the availability of sexual assault exams as a result of having this resource housed at Penn State and providing services across the Commonwealth. So we saw about a 270% increase in the number of sexual assault exams conducted in these rural contexts. We're up to, I think, about 320 exams that have been conducted in settings where they previously wouldn't be able to be conducted as a result of availability of this service. All right. The last area that I'm going to talk about is our dissemination outreach core, which is really our hub for community engaged research activities. And our focus within the doc is on engaging with our community partners and stakeholders involved in the child welfare response to identify research priorities, develop and design research studies with our colleagues in these community contexts, and then translate research that we get so that we carry out through the doc back to a broader policy and practice audience. We have two major resources that we rely on for this work. The first is we have an extensive array of data, administrative data holdings. And when I talk about administrative data, to people have a sense for what I'm talking about, I mean, we give you a quick sense that we're talking about records that are generated as a result of the clinical and casework involvement that individuals might have across multiple systems. And in the doc, we have access to statewide child protection data. We have medical assistance or Medicaid healthcare claims data for both the child and mother, juvenile justice records, and we also have county level records that we can use. And the second area of work that we've been doing is developing other data collection mechanisms to supplement that. So our doc has been carrying out a number of different surveys of children youth service administrators at the county level, juvenile court judges and probation officers at the county level, and then also engaging families that have been involved with child welfare services to understand what they see as some of the issues and challenges they face as a result of child welfare or child maltreatment system involvement. The big effort that we've had underway is our integrated data file, which links CPS involvement. So we have records of families involved with CPS over a period of years, and we've linked those individuals with foster care data, healthcare data, and juvenile justice data to be able to create longitudinal files that follow children within and across these different systems to look at outcomes as a result of their involvement with child protection. And I'm going to go through, I guess, 5, maybe 10 minutes, a few of these kinds of studies to give you a sense for what we're doing. The first area that we've been focused on is this, we've got partnerships with both child welfare and with juvenile justice And there was an interest in understanding what happens when you come into contact with both of those systems. That there's kind of a historical sense that it's important that we understand pathways children take to get from child welfare to juvenile justice and vice versa, as well as whether or not children and families are currently involved with child welfare with those two systems, or whether there is historical involvement with those systems to better understand how experiences in one system impact outcomes in the other system. And one of our concerns, and the concern that kind of led to this type of work, was that children in experienced with child welfare who come into contact with juvenile justice tend to experience more adverse or severe consequences as a result of that involvement. And so our study kind of built on that existing work to look at what happens when we deal with a statewide system. A lot of that work was based in New York, Cleveland, Chicago, and LA, really big urban centers. And we wanted to understand what happens when we look at crossover outcomes and processing bias in a larger complex state system. I'll skip through the methods here, but essentially what we're doing is we're implementing methods that these two groups are quite different from one another. Kids who enter juvenile justice with a history of child welfare involvement versus kids who are don't have that history. And when we implement our method, our selection on observables design, all of those group differences disappear, and we're able to then look at the causal effect of foster care involvement on outcomes in juvenile justice. In that context, we actually find that kids who are coming into juvenile justice with active foster care involvement experience less severe consequences in our state. There's little difference in terms of serious charges. Kids with foster care actually look a little bit better than kids without foster care in terms of the kinds of decisions and kind of restrictiveness of placements that youth experience as a result of juvenile justice contact. And we actually can kind of rule out that more punitive response finding that was popularized in the research literature. We've also done research on reverse crossover. So there's very little work out there that looks at this issue of what happens when adolescents come into child welfare and either have or a current involvement with juvenile justice or a prior history of involvement with juvenile justice. And using those same kind of methods, we're able to look at what the impact of juvenile justice involvement is on foster care placement and also on receipt of in-home services. And I'll skip to the finding here, which basically said that it's really only those kids that are actively involved with child welfare that we see an increase in the likelihood that they're going to be accepted for services, in-home services, or placed in foster care. So the kids who are coming into foster care with a history or into child welfare with a history of juvenile justice contact, but not active contact, actually don't look that different from the general population, even though they look quite different from the general population of kids entering foster care or child welfare in adolescence. I'll skip through this real quick. The last area I just want to touch on is we've been looking at this issue of health impacts for kids and families. And because we can link our child welfare system with healthcare data, we were interested, and our state was interested in understanding the ways in which child welfare system involvement might be implicated in identification and development of concerns for kids and families, and linking those kids and families up with appropriate services. So there's a number of policies that guide U.S. practices in this context. And when we look at this issue, I'm just going to show you a take on, so if you want to get to some questions and discussion. We have a sample of kids who are between the ages of 0 and 3 who are coming into contact with child welfare, and a sample of kids who have not yet experienced child welfare contact. And we're classifying them into whether or not their CPS case was substantiated, resulted in services, or resulted in placement. And we wanted to look at whether or not those differences in system involvement led to differences in identification of developmental concerns, as well as response to those concerns. These are kind of complicated charts, but the take home here really is that before CPS contact in that 0 to 3 period, those three groups look pretty similar. There's not much of a difference in terms of identification of disabilities. Once we see a family come into contact with child welfare, we see a pretty dramatic divergence here. That kids who are entering foster care are much more likely to be identified later on as having a developmental disability. The kids who receive in-home services are also more likely, but not quite as dramatically. And kids who are just substantiated but don't get any services look pretty similar, but are still a little bit elevated across compared to kids who don't have any child welfare system involvement at that point. And we also see that translating into access to services and supports. So kids who are entering foster care look pretty similar to the general child welfare population and to the general non-child welfare population at the point up to the point where they have contact. As soon as we see that system contact, the kids in foster care are much more likely to get linked up with services and supports, even though all three of these groups look pretty similar prior to that. All right. So the last point I want to make is that we're also heavily engaged in translating our science and research findings to policy and practice. So any of our studies often produce a brief that we can share with more of a lay audience. We've also done a lot of things like presenting our work to legislative groups. This is a picture of Theo Jackson down at the Capitol, the US Capitol, sharing some of her results with a special committee focused on children's issues. So we're really committed to trying to get that science out into the field, and especially into the hands of decision makers who are important in translating that science to practice and policy. All right, I know I kind of went through that pretty quickly, but I think hopefully the take home if this is that recognizing child maltreatment is a significant and complex public health issue. Affects millions of children and households, US and across the US and internationally. Results in significant adverse developmental, behavioral, and health outcomes, and involves many complex systems and contexts. It's really critical that we bring together multidisciplinary research to advance our understanding, looking at this from multiple different directions, multiple different systems, and multiple different strategies to improve outcomes. And in order to do that, it's really critical that we have the infrastructure supports in place to carry out this type of work, translating new science into educational training and policy contexts. And with that, I guess we can open it up for questions and comments. And I know I went through that quickly, but I'm happy to get email if people want to follow up and discuss these anymore.
Thanks, Christian, for that tour de force and getting through all of that. No, it was really, really impressive, and you really conveyed the scale of work that's been done in your centre and the complexity of that work. So just open up to any questions from people in the room, or perhaps if we have any questions online, but any in the room first off, any observations or questions from what you've heard?
What age do you finish the research on? I thought it's on 21. Could it go further than that, or do you ever do research in adults?
So the focus of our center really is on the children's experiences, but we do follow the child health study, for example, is going to be following youth up into adulthood. The first, and hopefully we'll continue to get funding to carry that forward into something beyond young adulthood. The other piece that we're primarily focused on are the role of caregivers in that process. So adults often come into the work of the doc by understanding the ways in which system involvement might impact the health and well-being of adult caregivers. So I mentioned that our integrated data, for example, has healthcare claims data for not just the child, but also for the maternal caregiver. And we're starting to use that data to understand how child welfare system involvement might lead to access to services and supports for moms who have behavioral health or substance use concerns, and then also look at ways that we can look at their health outcomes in the context of this data. The Safety Center is doing some work around adult victims of sexual assault as well, so not just child victims. But we haven't done as much in the way of retrospective studies, for example, looking at victims of child abuse and their adult outcomes. There are some work, so one of the aims of our center as well is to do what we call data harmonization, where there's another study at the University of Rochester that has adult survivors of child maltreatment. And we're looking at ways that we can bring together our data and their data and look at a much longer health outcomes trajectory. So hopefully that got it here.
Any questions?
Just going to ask Christian, thank you for your job.
Sure.
Getting all of those services to agree to share their data isn't an easy task. How did you go about doing that? And do they have access Are you the person who has access to all the data, or do they also have access?
Yeah, that's a great question. So there's different ways of doing this kind of work. And I would say there's better ways to do it. So one of the things I talk about at Tussle is kind of some lessons learned. In ours is very much driven on by putting together these data files and then making it really project specific. So we've got access to these data. The data come to us from each of the different state agencies. We had to go through a pretty extensive legal agreement process. So we have what's called business associate agreements that say I can be fired if something happens to those data. So it's very sensitive data. And we take data security very seriously. But those agreements allow Penn State to house that data, to use linking methods to connect those data, and then we take the identifiers out when we're working with data, but we don't share that data with anyone else. It's really the team of people who have to get trained on and onboarded to work with that data that have access to it. Another way, and I think this is something that the folks at Tussle work we're talking about, and the Care Pathways project as well. We're really thinking more about how to create an infrastructure to facilitate the linking of the data and then stripping identifiers out to make it available to different parties. So a data warehouse model is one that's often used. I wish that we had that, and that my vision long-term for this work is that we'll get there, but we don't have it at the state level. We do at the county level. So Allegheny County, which is where Pittsburgh is, has been really a leader, not just in Pennsylvania, but in the US at this idea of creating a data warehouse that can then link those data and make them available.
Thanks very much.
I think we're a far distance away from that here in Ireland at the moment. It's interesting that you've been having those conversations with people in practice.
Yeah, I think you all have some advantages. So we don't have identifiers that track across these systems. We don't even have identifiers that link child and mother in the medical claims data. So we do a lot of probabilistic linking of the data, but you all have some IDs, I think, that track across systems. Some barriers to using those IDs, I think, which is understandable. But yeah, I think that you may be able to make leaps and bounds with the progress once you get those agreements in place.
Like your optimism. Any other questions from anybody?
I'm surprised that psychological abuse is quite low.
Yeah.
How do you determine psychological?
No, that's a great question. So I think it's one of the limitations of using administrative data for those kinds of numbers is caseworkers often will not. I think it's probably understood that psychological abuse is a part of sexual abuse, is a part of physical abuse, but it's often not the driving factor that led to that child protection service involvement. So caseworkers, I think, sometimes are a little under or lower likelihood of kind of flagging that because they can flag something else. So, but I think it's probably a part of those other marketing experiences as well. And I couldn't find information on how that looks in the Tussle data, but so I'm curious at some point it'd be interesting to come see how our figures around types of knowledge experience compare with the types of experiences for youth.
I think one of the issues with our Tussle data would be that it's the initial point of contact. So the first reason that somebody presents with, and then they'll remind that we may have all these other issues, and they might figure about that particularly. Can I just ask a question, Christian, about the juvenile justice crossover? So you presented the data there on this study whereby children in foster care were not treated more punitively in justice processes. And that's somewhat counterintuitive to the previous studies that you kind of referenced there. What was the potential reasons for that, did you find?
You know, so one of the leaders in that work has been Joe Ryan, who's done some engagement in Michigan. Part of it may be our state context. We have a very different state system than I think a lot of that was based in LA. So there may be some just contextual differences in the experience of you entering the system. We've also, I think, we're kind of struggling a little bit with trying to understand some of those factors. I think part of why we did the reverse crossover study was I think there's probably some interplay between these two systems, child welfare and juvenile justice. A lot of our survey work has been understanding how the counties systems talk to one another across these two systems. So it may be that because the child welfare system has access to federal resources and supports, that it helps to manage some of those behavioral concerns in child welfare as opposed to juvenile justice. And so that might be why we're seeing some reductions in the justice system. But I think this is kind of, we're early in that process of trying to understand why that factor is happening.
Potentially really interesting that the quality of the care process might have an impact on the different juvenile justice systems. Imelda, did you want to?
That's such a good question. It's actually was one of my it's such a brilliant talk. I don't know where I have to choose my question, but you know, with regards to the dissemination and outreach, I mean, the kind of aims of your Translational Centre for Child Maltreatment is admin, the dissemination, and then the resourcing, support, and communication. You're trying on all angles to try and deal with this issue. Do you think one area is more important than the other? Because there is a lot of research in this area and a lot of longitudinal studies going on worldwide. From your perspective, like, where do you think resources and energies need to be put into?
In terms of the kind of advancing new research versus translating some of those findings into.
Well, translating research into you know, practice.
Yeah, I think the latter is an important one. And so I think one of the things that we're trying to do is advance research, especially around the biological aspects. And I think we're really excited about the range of data that's coming in through the child health study that will help us to disentangle that. But I do think I think what made our center grant particularly attractive to the National Institute was this idea that it's not just about doing the research. It really is about how do we develop a process where those results can come in, be translated out to that policy context. And so I think you've got a pretty active research agenda, not just the production of those briefs and briefings to these policy contexts, but also a research agenda in place around how to better communicate results to decision makers and policy makers, how to make sure that they have access to researchers, not just at Penn State, but we have an international network, a rapid response network that if a politician or a legislator has a question, they can send it to our network, and we'll disseminate a call out to our rapid response network that asks for people to bring us research and findings. So I think it really is about how do we develop the infrastructure, not just do the research, but to take that translation. And I think that's really the key development that we see in the field is that translation piece.
That's excellent. That's so interesting because it's like the decision makers looking for this, and then you disseminate it out and you get a strong response back. You know, this is what we advocate. Just one more question.
Sure, absolutely.
I had to trim it down. 4.3 million referrals. I mean, that to me was quite shocking. That's in this state.
No, that's across the U.S.
Oh, across the U.S.
In the state, we have about, I think it was about 220 referrals each year.
220,000.
Yeah.
So across the state, 4.3 million. But you said many of those, I think you said between 40 and 70% do not come in contact with the child welfare agencies.
So the 4.3 million, well, was it? No, I'm blanking on my numbers, but I think it was 3.1 million investigations that are done. So many, so that's just kind of the tip of the iceberg in the sense that the formal system involvement is about 7 million children and 3.5 million investigations, or whatever the numbers were. I don't know off the top of my head, but that only represents a fraction of the number of children and families across the U.S. who are actually experiencing it. So we know there are many more children than the ones in the kind of data that we're working with that are experiencing.
And I love the iceberg and analogy, because you showed where they're coming through, identified in other areas. So how do you address that? How do you get more that are going undetected into the kind of system where they get the support?
Yeah, I think so. One of the things that I think some of the strategies are to, and then there's a process here in or starting here in Ireland too, called the No Wrong Door. I think recognizing that children who experience maltreatment and trauma will come to the contact of many systems, right? So they don't just enter through child protection. They might enter through behavioral health services. They might enter through justice. They might be identified in educational settings. So I think recognizing that you need to link multiple systems together to understand the experiences of children and families is really critical. The other is that I think it's really important that we don't just focus on intervention services and supports, but we think about prevention. So I didn't talk about it today, but some of the efforts underway within the network are also about promoting community-based prevention efforts around child maltreatment. So the network led by Jenny Knoll and by colleague Kate Westafaro, who's now at NYU, have been developing community-based interventions, seminars and workshops that train parents to recognize signs of child sexual abuse that might be going on in their child and make appropriate reports, but also professionals in school settings and other contexts to better understand and recognize child sexual abuse and other forms of maltreatment. So I think coming at it from a prevention idea and an idea that we need to link and recognize multiple systems are involved in that response.
As you say, it's a wicked problem.
Yes.
Thank you.
Okay, I think our time is up here, and just like to thank you again, Christian, for your really interesting talk. And we'll be making the slides available with your permission to the TRIC members of the
I'm gonna edit one thing I said.
Thank you very much again.
Thank you.